welcome to this episode of Cracking Addiction. And we have Laura Petracek and Kate Butler with us. So I thought today we'd talk about how we can use DBT to help people in their experience with chronic pain. So first of all, Kate, what is chronic pain?
So chronic pain is basically any pain that has gone beyond the 3-month mark with experience, and where there is generally some pathology. However, the pathology is generally recovered from, but continues on. That's my experience.
So it's persistent pain beyond the time it takes for usual healing. And, we know that there are certain psychological factors that predispose people to experiencing this chronic pain. Would you be able to explain to us what these might be?
So people have traumas in their life that can affect their experience of pain. So generally people with anxiety or depression have worse chronic pain rather than people that do not. Sometimes if they've had a significant life stressor, realizing that you can't have children, and it just goes on and on. So losing a job can make the chronic pain worse, and their coping mechanisms aren't always there, so therefore they tend to catastrophize as well. Which makes things even worse and worse. And they tend to ruminate.
So you've used the word catastrophize. That's a specific psychological term. What does catastrophization mean? Can you give us a definition of that?
Where they think the pain is never going to end, nothing's ever going to get better for them. The pain affects them every single day. They can't see a light at the end of the tunnel because the pain is so bad.
Yeah. So really what I'm hearing is that really, trauma, mental health disorder, and catastrophization, they play significant roles in the perpetuation of pain beyond healing time. And they make significant contributions to the experience of chronic pain, or chronic non-cancer pain, as we've now know to describe it as. So going to Laura, we're hearing these phrases of catastrophizing, mental health disorders like anxiety and depression, and a history of trauma. As a psychologist, do you believe that there is a role for psychology in chronic pain?
Oh, most definitely, Ferghal. A psychologist in Boston, he wrote a book called The Full Catastrophe Living, Jon Kabat-Zinn, and he's a psychologist out of University of Massachusetts. And in their clinic, it is a pain clinic. And so he invented an 8-week mindfulness-based stress reduction program for people who had chronic pain. And then he later opened it up to other people. And I myself have actually gone through that 8-week program. And in this program, and in his book, he talks about what happens in each of the sessions, like teaching mindfulness, teaching meditation. When you talk about catastrophizing, it reminded me of one of the skills that's taught is called a thought record. So on the very left-hand side, it would be, I'll never get better. And then the next column would be a challenge thought to that. What's a more accurate appraisal? And then, looking at how do you feel after you say you'll never get better versus the pain is right now, or I don't know how it's going to be in the future. And this program, after doing a lot of research on it, found that it was extremely successful in helping people who have chronic pain. So I think his program, the mindfulness-based stress reduction, in addition to some DBT skills, would be very helpful for people that suffer, or are very helpful for people that suffer from chronic pain. because the outcome was their rating of the pain lessened. It went like from maybe 6 to 7 to 8 to 2, 3, or 4. There was a huge decrease.
Yeah. I mean, you've said a couple of key words there, Laura. I mean, yet again, you've mentioned Jon Kabat-Zinn, the great inventor of mindfulness. And you've mentioned the concept of stress reduction, so I think a lot of people, it's certainly in my experience, when I ask people, when you get stressed, does your pain get worse? They say no. And I think it's because they fear, a great fear that patients have that I've come to realize is they fear the statement, oh, the doctor thinks it's all in my head. And I think that fear blinds patients to the idea that stress really does make your pain worse. And that chronic pain, chronic non-cancer pain, fluctuates, and you do get exacerbations of it. And at least some of those exacerbations are due to stress. I mean, Kate, have you had that experience?
Oh, definitely. In my work, I spoke to a patient recently, and she'd come in for an exacerbation of chronic back pain. Very, very, very common admission. And I just chatted to her about, I said, oh, look, what's happening in your life at the moment? Has any changes happened? And she just said, she just broke down and started crying. And she said, oh, my husband's been going through all these health issues. And, he had a massive operation on his neck, and it's been really stressful and it's been constant. And I'm been caring for him. And, that just happened in the last 4 months. And this pain started in the last 4 months. And I said, okay, cool. So we need to tackle this from a different perspective.
Would you have a comment to make to that, Laura?
Yeah. First, I'll make a comment to your comment or what you shared, that patients are afraid to disclose or to agree with stress is causing their pain. In addition to maybe feeling that we would look at them as, oh, it's all in your head. Of course, a lot of that is they're afraid of being judged. So they're not going to say that there's a connection because people don't want to be judged or they don't want to feel shame. And I think, referring to what Kate's shared, that's very common, especially somatic therapy looks at connecting, okay, this is the stress. You say it's presenting itself with back pain, but what's going on in your life, like Kate had asked? Because I do think there's a strong connection to physical pain and the emotional pain that's happening in our life. But for most people, we're from a society that it's okay if you have a back pain or shoulder pain to go see the doctor. But if you go and say, hey, my husband had this horrible surgery, the doctor's going to be like, what? Like, I don't know what, we're not, that's not as accepted talking about as emotions as it is to talk about physical problems. And whether it's Australia or America, it's definitely in European countries, it seems to be the norm that it's okay to go in and say, I have back pain, but not about the emotion of what's happening, the situation.
So another couple of things that I think about when I consider chronic pain is I consider the idea of the pain insensitive warrior. So we've all heard stories of absolute heroic deeds done by people who have experienced significant trauma, be it on the battlefield or be it in some kind of civilian catastrophe. And they don't experience pain. And yet we've also got patients who, for various reasons, and especially if there's a history of background childhood trauma, experience significant amount of pain, and there doesn't seem to be any actual tissue damage. Mm-hmm. How do you reconcile those two presentations? What's going on, do you reckon? So, Kate, I'd like your opinion on that.
It's difficult when there's actual no tissue damage. However, generally, in regards to what we teach with regards to trauma, people can have had scar tissue, and scar tissue can pain associated with scar tissue can present at any time. It may have been underlying at the time, but it could be that stress has affected their coping mechanisms, whereby they can't cope. They can't maintain that homeostasis and deal with that anxiety because of their life stress. So therefore, pain is more significant in their lives because of the stress. Is that something that could be a theory around that, maybe?
Mm-hmm.
Well, what about the hero that doesn't suffer pain? How do you explain that?
I would say that's the adrenaline.
Yeah, and there are specific mechanisms between the top of the back of the brain and the spinal cord that block pain signals from the rest of the body, and that's associated with the adrenaline rush, isn't it?
Definitely.
But there we have a perfect example of the relationship between the experience of pain, or the variation in the experience of pain, and the brain's cognitive state. What do you say to that, Laura?
Well, I think there is a few things. The hero that experiences no pain, part of it is the adrenaline, but I think also part of it is thinking it's a selfless act. So they're not thinking about themselves. They're thinking, I want to rescue this person who's stuck under a car. Or I think about this one movie in World War II, the title escapes me at the moment, but this guy, already wounded, went up and back this hill, this battlefield, to rescue like 26 men. And he kept saying, I want to save just one more. Just one more.
Yeah.
Now that
I think the movie was something with Edge in it.
Yes. And it was just
Razor Edge?
Yeah, something like that. But it was just so powerful to watch it. And not just watch it, but to see his dedication to mankind or his fellow man. Like, I'm not going to think about myself dying. I'm going to rescue. My focus is on you, rescuing you. And so it's this altruistic feeling as well. Whereas someone who can't tolerate a lot of pain, I think, yes, it's connected to childhood trauma. And I think there may be, and I don't mean to be judgmental, but some of it is also self-involved. Like I heard, my nail fell off, or, it's a minor, quote unquote. I mean, I guess it's all relative how you view it, but I think clients that are more self-involved experience pain in a greater way than the hero does, because they're not thinking about anyone else. And not that, everyone has to be altruistic all the time, but, again, going back to that movie, and I'm sure there's millions of different examples, but I've seen it in my own patients where, one patient, she got hit by a car on her bicycle, and yes, the adrenaline was, I think, keeping her from crying as she shared it, but also she kind of grew up in a like, you have to be tough background, like not crying, not that crying's not allowed, but more, it's the pain is equal to whatever happened, I guess, for whatever. Whereas in someone else, they got rewarded for, oh, I fell down, scraped my knee. Oh, that's terrible. I never want you running again. Or, I think that's part of the factor too of parenting factors.
So we've looked at the relationship between the past and the experience of pain, and the mental state and the experience of pain. That's all well and good, but what are the psychological techniques that can be used to actually help people with chronic pain? I mean, Laura, you've mentioned at the beginning of this chat the possibility of mindfulness-based stress reduction. You know, what you as a psychologist, how do you help people with pain? What techniques do you use?
Well, one technique is teaching mindfulness and meditation. So in terms of teaching mindfulness, like taking them through, what are you aware of now? And now? And now? What's, teaching them, taking them through a body scan. Let's go through each parts of your body. And what are you experiencing? And then, because a lot of clients are so not in touch with their body. And then another skill is looking at meditation. Yes? Or did you want to say something? Another skill is looking at meditation. And then I have some DBT skills I could also recommend.
So given that you're an expert in DBT, Laura, pray tell, what are the specific DBT skills that you can use to help people in pain? Because really, we're talking about chronic pain really as a cognitive construct, aren't we?
Yeah, it is. So one of the DBT skills is called ACCEPTS. That's the acronym. And it stands for getting involved. A stands for activities. C is contributing, like being of service, getting out of your own head. The other one is compare. Basically, if you compare, or in the 12-step program, they call it compare despair. So there's always going to be people greater or lesser than ourselves, or more pain or less pain. But if we compare ourselves to them, it's usually ends up on the negative. Emotions, letting emotions flow, looking at your thoughts. And this is where I do a thought record, which it's a CBT skill I find very helpful. And then S is distract yourself with sensations. Maybe take a cool bath, go out in nature, eat some ice cream, go dancing. So that's one of the DBT skills, is called accepts. Another one is called improve. And improve stands for improving the moment. So we're looking at imagery, so in the groups or individual therapy, showing pictures. My office is connected to my backyard, so I usually take clients out there just to look at the trees and maybe pick an orange or a lemon and smell it and, try to, again, get out of their own head. M is meaning. And this goes back to Viktor Frankl, who said, if there's a why, then a person could figure out the how. If someone has a purpose, it helps them more accept the pain, deal with the pain, than if it's just a never-ending, enduring the suffering. That is a lot tougher for someone to tolerate. But if someone has a purpose, or if there's a why, I'm doing this for my kid, my job, whatever the why is, the more the person can persevere. And P stands for prayer. And prayer doesn't necessarily have to mean religion or God or a higher power. I remember one line from Mary Oliver's poems, many poems. She goes, I don't know how to pray, but I know how to pay attention. And that is a form of prayer, paying attention to this moment. The R for relaxation, doing yoga, going for a walk. The O stands for doing one thing at a time. So for AA, this is really big. 1 minute at a time, 1 day at a time. That's how you tolerate not picking up a drink or a drug. How do you tolerate pain? 5 minutes at a time, 5 seconds at a time. How do you tolerate the craving? 5 minutes at a time, at least initially in one's recovery. The V stands for vacation. Not everyone could, of course, up and go somewhere. So, I think it's something you have to plan, and I think it's a great idea. And then encouragement, get support, be in a support group, like, one of your support groups, or find one online. And also, so those are some of the skills: accepts, and using distraction skills.
How does that sound to you, Kate? Is that something that could be used in the cohort of patients that you look after?
Definitely. It's more of a question of whether the patient would be accepting of that in that time or point. Usually when they come into an inpatient space, their stress is at their max, and that's the reason why they're presented to the facility. And thinking about that, not everyone's willing to engage in something like that. I have used in the past, I've talked to people about mindfulness techniques, and also about how they've used that to modulate their pain. I do try to teach patients grounding techniques if they get intermittent pain, or function causes their pain to get worse. And they're very open to it sometimes, but not everyone is. So I think it's about finding the right amount of right patient cohort who are open to that. Not right, but suitable in their recovery journey as well, because they're not necessarily able to be open to those non-pharmacological therapies, because they're so attached to what they normally take, and they just believe increasing the dose or trying something different will change it.
It will make it worse.
Yeah. So, and I work in an inpatient setting, so the reason why I want to look into these types of techniques is because sometimes when they come in their crisis, the only option is just to refer to a clinic where there's a massive wait list. So I was trying to give them tools to exercise, when they go home and practice. So maybe they could try to alter their pain experience while they're waiting for other support networks.
So unfortunately, we run out of time once again. I want to thank you both for your expert contributions to this fascinating discussion on psychological interventions for chronic non-cancer pain. But thank you both. That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.